Hi, everyone. My name is Kanisha Gala. I'm a project owner at LARVOL, organizing the AACR Hematologic Malignancies panel discussion that we have organized today. With me, I have Dr. Vinod Dakal, and we are really excited. Thank you so much for joining us. We're really excited to hear about your insights and opinions on the abstracts we have selected today. So we are actually going to start with the ZUMA-5 abstract. So ZUMA-5 is a trial that was presented last year at ASH and resulted in approval of Yescarta for relapsed refractory indolent non-Hodgkin's lymphoma very recently. And so this study in particular is looking at product attributes and immune-related biomarkers associated with clinical outcomes, trying to ascertain the mechanism behind the clinical efficacy. And I'm going to hand the reins over to Dr. Duckal to just give us a brief overview on the study.
Thank you, Kanisha. So this is, as you said, this is a follow-up study, or as you call it, is a correlative study to look at the predictors of, any predictors looking at the composition of the CAR T cells or the biomarkers that could predict the efficacy and the safety of this construct in the ZUMA-5 trial. So in this study, there's exploratory analysis being done besides the primary endpoint, looking at mainly three things. The one is the product attributes. How does it affect the efficacy, the level of the CAR T cells, and the level of serum biomarkers, and then what is the attribute to the patient when they relapse after this, this therapy. So they looked at all these factors, and they want to correlate that with the efficacy as well as the toxicity. As we all know, the two main toxicities that are associated with the CAR T, including this axi-cell construct, is CRS and the neurotoxicity. So there is a lot of interest in understanding or predicting, any kind of biomarkers that could predict the severity and the grades of this neurotoxicity before or right after the treatment to select these patients who are at high risk of this toxicity. So the results of this study are very interesting, and as pointed out in the abstract, there are when they just looked at the CAR T cells composition, they found out that those patients with the higher levels of naive T cells, the CAR T cells have a higher chance of ongoing responses. At the same time, they also found that those patients have the higher rates of grade 2 and grade 3 neurotoxicities. Then they looked at the several biomarkers, both post-treatment, post-CAR T, and also at the pre-treatment. And then they have some interesting observations there. For example, if you have a higher, levels of some certain biomarkers like interferon gamma, interleukin 2, interleukin 6, even CRP that we checked on these patients, then there is a higher chance of these patients having greater responses. At the same time, when you look at certain biomarkers before the pre-treatment, before the infusion of the CAR T cells, then certain biomarkers is associated with the higher relapse rates. For example, if you have higher levels of IL-10, interleukin 16, and even TNF alpha, among those several biomarkers, then the rates of relapse are higher in those patients. And they also found out that in patients who are relapsing, the levels of the naive T cells are low levels as compared to the patients who have ongoing responses. And I think the most important observation is that, when they biopsy all these patients who are relapsing, there were 100% of them have CD19 positive. So what it highlights, underscores the fact that immune evasion is, or the target evasion is not the only mechanism these patients relapse. It has to do with the several attributes of the CAR T, for example, the composition of the T cells, the several biomarkers that are associated with that. Because interestingly, all 100% of patients are CD19 positive. And lastly, when they looked at the other biomarkers, certain biomarkers like interleukin 6 and interleukin 2, several other biomarkers, GM-CSF, those biomarkers were also associated with the high rates of neurotoxicity. And because of that differences in the biomarker level between follicular lymphoma and marginal zone lymphoma, the rates of neurotoxicity also vary among those two different subtypes. So I think it's a very interesting study. The first time they're looking at several predictors of the outcome or the several biomarkers that we could detect or we could look into in understanding or predicting the efficacy and the safety of this construct. And it is very important to look at that because right now in immunotherapy is taking a center stage in several cancers, including lymphoma and myeloma and other hematological malignancies, hopefully. But we don't, have any modality or any kind of a platform to find out who are the patient who respond to the immunotherapy best, and also at the patient who gets severe side effects from this immunotherapy, because there are also some certain side effects that we need to be worry about.
Right.
And make sure the patients are selected appropriately. So I think this is the first step in helping us understand and selecting those patients.
Mhm.
I mean, one of the drawback, of course, is there are so many biomarkers which could be non-specific to that particular construct or particular disease type, and may need further validation in larger studies. But this is definitely one important step in that process.
Excellent. Great. Thank you so much for that overview. And to touch on some of the things you highlighted in your introduction. So how routine is it to do biomarker testing on these patients to, identify?
I mean, it's very routine that we look at certain biomarkers in on trial, off trial, after the immunotherapy, in particular the CAR T therapy or bispecific antibodies. The most common are very crude biomarkers, especially looking at the inflammatory markers like CRP, ESR, ferritin. So that is very common.
Okay.
IL-2, IL-6, they are sometimes measured, but not in day-to-day basis. We don't measure all these, several biomarkers that have been listed, at least in the real world setting.
Right.
But if we have like a, greater evidence, bigger evidence, and also more robust data in the larger scale setting, that this certain biomarkers that is more sensitive and more and better predictor of the outcome or of the both efficacy and toxicity, then there will be the people will be using this in their routine daily practice. But right now, definitely, we are limited to certain non-specific biomarkers.
Mm-hmm. And you touched on some of the challenges associated with toxicities, in this patient population and dealing with the CAR T therapy. The other potential challenge I wanted to talk to you about is maybe sequencing or deciding the best appropriate therapy for this patient population. So, in the first abstract we were going to discuss, there's targeted therapy, and then obviously chemotherapy, and now CAR T therapy for indolent non-Hodgkin's lymphoma. How does sequencing play into that in your clinical practice?
So, given the lack of the head-to-head data, it's always you have to make a judgment call in which is the best therapy for that patient.
Yeah.
So again, if you look at in general in the broader kind of a picture, so if you have a drug which is have the same label for the same line of therapy, then you choose one particular therapy based on the patient characteristics, disease characteristics, and treatment characteristics. So all those factors play into role. Unless and until there is a head-to-head data comparing, those two new therapies, but which we don't have at this time. So for example, somebody you're choosing for CAR T, you want to make sure the patient is fitter, the patient has no other major comorbidities, prohibiting comorbidities, and something that would put the patient at high risk of certain toxicities. And at the same time, we also have to make sure that the patient doesn't have like a rip-roaring disease, going on, that the patient cannot wait for the CAR T manufacturing, all those stuff. So those kind of factors play into role. Both the therapies will have a role, and then at a certain point of time, which one you choose at one point depends on those factors at that point of time. So, if you look at a disease like indolent lymphoma or multiple myeloma, where you will end up using these therapies at some point of time, even if you choose, let's say the patient is not ready for the CAR T, even if you choose the other therapy because you have that rightly available that you can offer to the patient might be eligible for CAR T at some point of time. So sequencing can happen in that way, but at the same time, in the absence of like a data of how to sequence this regimen, you just have to rely on those factors, the patient-related, patient factors and disease-related factors and all those stuff. So.
Excellent. Excellent. Great. And so I just want to, maybe end this discussion. Oh, hi, Dr. Landgren.
I apologize that I was so profoundly behind here.
Oh, no problem. We started with the Zuma 5 abstract. So we'll go back to the Chronos, but just to wrap up this discussion really quickly, Dr. Duckel, I wanted to know, so, I'm assuming that Zuma 5 has significantly impacted your clinical practice. Do you mind touching on that?
So, in our place, we have our own in homegrown CAR-T as well that we offer to our patients. Okay. But at the same time, we do offer this construct to somebody who is not eligible for our own home clinical trial. And there are a few patients that we're already treating it. And it's pretty exciting to see the responses in these patients and then continue to have ongoing responses. So.
Excellent. Excellent. Great. So it's a pretty exciting approval.
Mm-hmm.
Excellent. Great. Okay. We will wrap up this discussion and head back to Chronos 3. So Chronos 3 was a randomized phase 3 study of copanlisib plus rituximab or rituximab and placebo in the same patient population, relapsed indolent non-Hodgkin's lymphoma. Dr. Landgren, do you mind giving us a quick introduction on this abstract?
Well, I guess this is a combination of non-chemo based therapies for patients in this particular setting compared to placebo with rituximab. And Matt Matassar was the first author of this study, this presentation. And here we now have another example in cancer medicine, how you can achieve great results with chemotherapy-free combinations. Mm-hmm. The median progression-free survival was reported to be 21.5 months compared to the placebo of 13.8 months. This is obviously highly significant with a hazard rate of 0.5. I think every 6 months I see a new presentation showing how the immunotherapy is just moving forward. And I think in 5-10 years, we will think about chemotherapy as something that we cannot understand how we could be using in our clinics.
Great. So based on that introduction, my very first question is, do you expect this to impact your clinical practice and be practice changing?
I think this is definitely impacting. This is a large randomized trial, and I think the data are quite striking. So I think a couple of things that impact clinicians, in my opinion, is randomized large study, hazard ratio that's significant, but most importantly, that there is a meaningful progression-free survival difference. And if you go from 13.8 to 21.5, that's definitely clinically meaningful. I think we can argue back and forth if there was 1 month benefit, even if it was significant. I would not consider that to be meaningful. Is 6 months, I would say. So now between 1 and 6, you could go back and forth. So in my clinical opinion, I think when new therapies come out and they show at least a 3-month superiority, I think that's when they start getting traction. And here, clearly, you pass that point. So that's kind of a rough estimate of my read of the clinical literature. So I think definitely this, in my opinion, does.
Impact clinical practice. Great. Excellent. Dr. Duckel, I wanted to ask you, so, here some of the toxicities that were mentioned include, diarrhea, hypertension. Obviously, Dr. Landgren just pointed out that the results are very significant. Are those toxicities concerning to you if you were to prescribe this therapy?
Yeah, I think that's, you rightly pointed out, this a little bit concerning about the grade 3 toxicities are higher in the patients who got copanlisib plus rituximab versus rituximab. And especially, if you look at the grade 5 TAs, there were 6 patients on that, and then versus none, or I think no, 1 patient in the other arm. But this is, is with if you add another therapy on top of existing therapy, you're likely to get more, kind of added toxicity. There's no question about that. But if you look at the risk and benefit, you have to adjust the risk and benefit in this setting. And if you look at it, as Ola pointed out, just compared to the single agent rituximab, even if you retreat these patients single agent rituximab, I mean, the PFS benefit you are getting is almost double using this PI3 kinase inhibitor, copanlisib. So I think choosing a right patient in those patients who are not able to get intense treatment, including the CAR T-cell therapy, this is an important option, and we have to choose the right patient. I think if we choose the right patient, I think you should be able to derive the benefit in those patients.
Excellent. And you just brought up something that I, now want to ask Dr. Langren about. You said 4 patients that are not eligible for CAR T therapy. And so is that the same sequence, Dr. Langren, that, you potentially follow too? The very first option you look for is eligibility for CAR T, and then if not?
Well, I think that's a fair way of thinking, but I also think that not every patient lives nearby a large center, and not all centers have set up their program to deliver these therapies, the CAR T cells. So I think to a high degree, yes, but I still think that availability is also something that impacts the utility of the different therapies. And if you go outside the United States, I think even more so.
Excellent. And so some of the challenges that, were just discussed had to do with toxicity in the copanlisib arm. You just mentioned availability of different therapies, specifically CAR T. I think that's a bigger concern for CAR T. Are there any other challenges for this patient population in determining therapies, the most appropriate therapy?
I'm not sure I captured that question.
Oh, sure. Sorry. So we discussed multiple, challenges in terms of figuring out the best therapy for this patient population. One being maybe some of the toxicities associated, grade 3 toxicities associated with this targeted therapy. You mentioned availability of the CAR T therapy being a challenge. What are some other considerations that go into?
I think in my mind, thinking about like how patients with all the different types of malignancies kind of are facing options, and how things kind of impact decision making. I think the list is sort of the same. I think it's if you're talking about the relapse refractory population, have the prior therapies resulted into some toxicity that now kind of hinders us using a therapy that kind of has similar toxicity profiles. So you maybe cannot, if you think about drugs that cause neuropathy or cardiovascular or renal, that could be something. Does the patient have underlying comorbidities that limits the utility of certain therapies? Is the patient frail? So all these things like kind of circle around what's the patient overall status. Mm-hmm. Then we touched on the fact that availability is not the same everywhere. Although in the US that the same drugs are approved everywhere, people don't live close to centers, or it's just practically not feasible maybe for all patients to travel far. They just don't prioritize that. Yeah. Then I think also increasingly so, I think in my clinic, patient preference, I think comes more and more into play as we have more and more options. I think clinical medicine, modern clinical medicine to me, has gone from being like the doctor telling the patient what you have to do to having a conversation with the patient. You still would recommend something, but I think it's much more in conversation with patient, and patient may choose and prefer certain therapy over others. So I think it's just not only the hazard ratio, the PFS and things like that. It's just like, what are the other options? If you pick one over the other, could you then do the other over the first one, and so forth, if the disease were to come back? So I think it's a very complicated algorithm as the answer to your question. Yeah. I don't know what you think.
No, I think I agree with Ola. I think, it's not only an indolent disease like lymphoma, other diseases like myeloma, also the same thing. We have so many options, and sequencing is, always challenging. And, unless there is head-to-head data, we cannot say this is what it looks like. But given the fact that we have so many options is a good thing. We can offer to the patient, and let the patient decide. But at the same time, you can guide, what are the potentially best therapy based on the patient characteristics, disease characteristics, and all those stuff. So I think each of these therapy will have a role.
Great. Okay, excellent. Thank you so much. I think we have a good picture of what the landscape looks like for, relapse refractory and non-Hodgkin's lymphoma. I'm going to spend the last 5 minutes or so on our third abstract, which is interim analysis of avapritinib in patients with advanced systemic mastocytosis, which is obviously a rare disease than what we were just talking about. Dr. Langren, again, do you mind giving a very quick introduction?
Yeah, so this is obviously rare, as you point out. Systemic mastocytosis can be a very complicated disease for patients that have that, with a lot of problems with diarrhea, skin reactions, breathing problems, like emotional, blood pressure, everything. The condition is considered to be driven by a KIT D816V mutation in the majority of the cases. And there is a phase 1 study showing that the KIT D816V inhibitor has been found to have a durable response and deepen over time. And I believe that's why this particular study, the Pathfinder, was launched. There are 62 patients that were enrolled, and the results were in the abstract here. The median time to response was 2 months. The median overall survival was not yet reached. The estimated 12 months is 87%, so that's pretty good. Let's see, I actually didn't capture, I didn't write down the details for all the other details of the response, but I think the overall is that it's a rapid response. They gave the 200 milligram QD, and it was generally well tolerated, and you had thrombocytopenia as one of the side effects, I guess.
Great, thank you so much for the introduction. Dr. Duckel, going over to you, very broad question, but do you expect this to be practice changing?
I definitely think so. This is, I have few patients of this systemic mastocytosis, and the struggle we have is there is no effective therapy. And as Ola pointed out, it can be very, interfering with the quality of life with a lot of symptoms. This patient have bad skin, and whatever you apply doesn't get better. A lot of systemic symptoms, constitutional symptoms. So it's pretty bad, and there is no, a very effective therapy the patient can take unless you want to do for a stem cell transplant, which is a big procedure for these patients, and not everybody will be eligible for that. So I think and the available drug is only one, midostaurin. That's the only one option we have. And if you look at the response rate, 1/3 of the patient will respond. I have used in one patient, and the other patient, like 1 or 2 patients with the modest success. But I think having this looks very potentially very powerful. At this stage, it's a phase 2 study, but it looks very promising. And if you look at the data, the median time is very quick response. Everything, they have very deep responses. More importantly, if you look at the tryptase level, the D6, the VAF level, everything went down, and very well tolerated except for the cytopenias. So.
Great. And just in terms of trial design, given that this is a rare disease and patient accrual might be a problem, how reflective is this patient population of what you see in the clinic? Dr. Landgren, we can start with you.
Well, this is the forever problem. When you study rare diseases, you have to live with the fact that there is a lot of uncertainty. So if the study only included 32 patients, of course, the confidence interval, if you put around, for example, the overall response rate of 75%, the confidence interval, I have not done the math myself, but I would assume that it probably goes from 50 to 100%, something like that. Mm-hmm. It's very hard to know in the real world what these numbers are, but given the fact that this is it's a very, very difficult disease for patients, we have no other there are no other good options, or very limited other options. I think the signal here is very promising, and I still think that for that reason, this becomes very attractive, and I think it's practice changing.
Great, excellent. So I just want to spend the last 2 minutes, kind of allowing both of you to discuss what is the new therapy on the horizon that you're most excited about, and very generally speaking across hematologic malignancies, whether it relates to the abstracts discussed here today or not, just, what are you most excited about? And Dr. Duckel, we can start with you.
As we saw a lot of revolution happening in immunotherapy. So I think immunotherapy in some form is the most exciting part right now. Whether it's one immunotherapy or combination immunotherapy is a question. I think the future is probably going to be a combination of immunotherapy. Whether it's CAR T followed by BiTE versus other stuff, but it's some form of combination immunotherapy is probably going to be the backbone of a lot of hematological malignancies, particularly lymphoma and myeloma. That's what I think we're very excited about.
Excellent. Thank you so much. And Dr. Landgren, same question.
So we did not rehearse this, but you're going to hear the same thing from me. I think definitely the immunotherapies are coming, and maybe I put a little extra spin on that. I think in the myeloma field, for sure, I think that the bispecifics are going to drive the field. There are so many of them. There are 25 of them in development. There is a range of targets. It's not only BCMA, there are other targets as well. And they all show 60 to 80% overall response rate in patients with 6 to 8 or something median prior lines of therapy, and up to 12, 15 prior lines, even in some of the trials. I think we're going to see chemo-free therapies. And I think partnered with earlier potential initiation of therapy, there have been presentations published the past 6 or so months showing that you can also genomically capture people who are going to develop symptoms in a short period of time. I think that opens up a new avenue. If you could start therapy earlier before the disease has completely evolved, you could harness the disease with immunotherapy without causing all the harm that chemo does. And then I think on the back end of that, if you could partner that with sophisticated minimal residual disease detection and rule out residual disease, I think that could potentially be a path towards a cure for diseases we thought were not curable.
Wow.
Those would be my 2 cents.
Excellent. Well, thank you both so much. We really appreciate your insights in this discussion. Thank you again.